you should have men's and women's health. These are actually the slides that we didn't get to last week, and so we're going to finish up on those. As most of you know, we're using Zoom, which we've had better luck with it, and Dr. Steinman basically thought that it would overcome some of the problems that we've had. For example, the delayed recordings and things like that, which has just been very frustrating to us, and we know it's been very frustrating to you guys. So, so a couple of things which, from feedback you guys have given me this last week. So we'll do the post-test tomorrow, and Aiden and Marissa will put the post-test answers up probably a day or the following day. So we'll not only put the answers up, but we'll put the questions up so that you will be able to look at those. And again, one of the things on these pre-test and post-test is that don't worry about what your score is. Basically, we are required to do these now. And so the main thing is you're getting credit for taking the pre-test and the post-test, but your score doesn't, whatever you made on that is not averaged in to your grade. So that's first thing. The other thing, just like last week, there are some questions that are incorporated into the slides. And another thing that we need to do, basically, to make sure we get you guys can get CE credit. So we had to do that. But I will tell you that with regard to the questions that you're going to get this weekend and probably the next time we meet, is some of these questions are, they're not just simple A, B, C, D. So for example, some are short answers, and for when we get to one of those, I will tell you. So what we'll do is you'll just sort of answer on there and just, bullet points, and you don't have to give, for example, if I ask, what could this be, or what other thing is, all I'm expecting is you to give one or two answers. So there may be a list of 5 or 6. And so hopefully between the class, we'll cover most of those. And so there's a few that are more than just, true, false, or multiple choice. So be aware of that. This week, I hope you guys have access to a stethoscope and to a blood pressure monitor. We will be getting into that. So we will start taking vital signs. Those we will probably get to. It most likely will be either late today or tomorrow. There will be some videos that I'm going to have you watch. That will be something else that's there. And then the last weekend that we meet, we will have a little bit different situation, whereas the Saturday will be taught by another faculty member. I think it's the first time she's taught in these cohorts. But basically, I believe she is a nurse practitioner, and she is going to be doing some more of the, she's going to be doing some of the actual physical assessments exercises with you guys. I'm going to start using some cases this weekend, so you will get a couple of cases where, unfortunately, I say that unfortunately because I know you guys will have done this before, but one of the things that I will give you most likely tonight will be a case for you to write up a SOAP note on. And so we'll give you some of this information. The other thing is, I know that in the years past, and I think it's true for this course too, is there's a diversity with regard to the background of the individual. Some of you have done some physical assessments and done some things on very, very frequently. There's others that have not done so much. So what I used to tell my other students, both psychology, pharmacy, and medical students, is if you've done it before, look at it as you've got the experience, or you have, some of the experience, and so therefore this should be fairly easy for you. And feel free to, to make some suggestions or input. That's going to be especially one of the things with physical assessment we do find is that individuals, you will develop your own style. And what you will do, one of the things that, that will be good will be that just simply, when I say your own style, is for taking a blood pressure, you will develop slightly different ways in which you maybe put the cuff on, or how you go about doing this. And some of you that have done it differently, please chime in. And because one of the things with people that haven't done it as much is for them to try to get a feel for what works best for them. So there are some slight differences in how people may actually approach this. Just for example, one of the things we're going to talk about today is I'm going to be, or today and tomorrow, we'll be talking about like when we're doing a, getting a medical history and things like that. I'm going to be talking to you about some of the questions. You guys actually have more experience than a lot of healthcare professionals. For basically what you guys do, you tend to be more communicable, which is good. And that does not necessarily mean I've had psychologists that see patients all the time, but when they get in the mode of maybe getting physical assessment, sometimes it gets them out of the norm of the type of questions that they need to ask. So again, I'm going to give you some examples of questions and things to look for. And that's not only going to be today and tomorrow, but also next weekend, not next weekend, but the next weekend that we meet. So again, those of you that have had a lot of experience, what I would encourage you to do is that if you have some comments, if you have suggestions, let's put those in. Because again, when I came through, I had a very strict person that basically said, you have to do it this way. You have to do it this way. And what we found out is that basically I learned to do it that way. And then when I actually, was, for example, taking a lot of blood pressures, I learned that there was some slight changes that could occur, which just made it easier for me in doing that. So any additional suggestions that, again, when I'm giving you this, we're going to, and also when Alice is talking to you next week, or when I say next week, it's not next week, but the next weekend that we meet. It's, again, input and questions. Some of you will find that with taking some of these physical assessments that you just feel awkward. And I will guarantee you most people did that. And so it's a matter of just practicing it. Okay. All right. So again, what we're looking at is we're going to start off with today looking at men and women's health. Basically, we had covered a number of lab systems up through last week. And the one we didn't get to was the ones that really focused on men and women's health. And you guys will have to bear with me because I've got to get used to using the different controls here. I think you can see my mouse on here, and I'm going to see if, let's see if I can use a pen here. So let's start off with one of the things that's important is when we're looking at lab values, just like when I told you last week that we met, one of the things that we want to say is that we want to say, where do these lab values go? How do they sort of fit in? So like when we talked about the liver, one thing I told you is that the liver cells pretty much when the most of the enzymes that we're looking at are actually within the liver cells themselves. And so when the liver cells die or get damaged, the cells open up releasing the enzymes, which is why we see an increase. So for example, when we're looking at AST or ALT, what we're looking at is elevations tells us that there has been damage to the liver because the intracellular enzymes have been released. Now, today we're going to talk about some of the hormonal components, and we're going to be looking at the hypothalamic pituitary ovarian axis. So this slide should be familiar to you because I think we had a similar slide or closely similar slide to this before. And it's important that we understand this relationship so that we can put into perspective what these changes would occur. From your practice, many of you are going to deal with women that may be having some emotional or mental issues associated possibly with their periods, possibly with postmenopausal. You're going to be dealing with males. Some individuals, males, we may be dealing with some of the effects of where they have a hyperandrogenic state. And so that elevated testosterone or something may be accounting for aggression, or we may be dealing with someone that's depressed or has some sexual problems, both males or females, that may be due to a deficiency or dysfunction of this system. I will tell you that when we're looking at these particular hormones, one of the things that we end up doing or makes it very difficult is the fact that there's such a fluctuation that can occur. And so sometimes a single measurement is probably not as accurate as what we would see with potentially thyroid. Okay, so we want to be careful about that. And sometimes there needs to be multiple measurements. And sometimes what we see is, depending on the state, for example, women moving into menopause, that there may be some fluctuations. Women that are pregnant, there would be fluctuations depending on it. Even women that you're trying to figure out that may be having some difficulty with their periods, this may be an issue too. Sometimes it is very difficult to sort this out, and we need to identify an endocrinologist. And endocrinologists, I don't know how easy that you guys have access to them, but what I've found in general, that a lot of endocrinologists are in awful high demand, and many times it's difficult to literally get into their practice or to get a consult. Sometimes you're fortunate that you may find a general practitioner that seems to specialize or has a good knack for this, and they may be an individual. So let's just review very quickly. This should be something that's readily apparent to you. So we know that what's going to happen is we have the hypothalamus is going to stimulate the anterior pituitary to basically release. So the hypothalamus releases gonadotropin releasing hormones. And these are identified as basically, typically we define these as GnRH, okay? Now be careful, because it's easy to confuse growth hormone releasing factors, which is GHRH, okay? So typically it's G little n RH. So for example, let me just put it here so we got it here. So GnRH is going to equal gonadotropin releasing hormones. Don't confuse with GHRH, which is going to equal growth hormone releasing hormone. Those are two that you can sometimes get confused on. So the gonadotropin releasing hormones comes from the hypothalamus, which then causes the anterior pituitary to release gonadotropins. And the gonadotropins that we see released are LH, which is luteinizing hormone, and FSH, which is follicle stimulating hormone. Those compounds will then affect the gonads. So in the males, it's the cases we look at the testes, and in the females, it's the ovaries. And so the testes will stimulate testosterone production, and the ovaries will primarily release estrogen and progesterone. However, we're going to see that both in males and females, and I think you guys know this, is that although the predominant hormone in males is testosterone, males do have estrogens and progesterones at much lower concentrations. Same thing in the females, we see the predominant is estrogens and progesterone, but females also have some testosterone. So, from a standpoint of evaluating the system, we may look, and I will show you some examples of this in just a few moments, of where that testosterone levels in a female may account for some actions. This is, again, a negative feedback. So what we find is as the hormones increase, so whether it's testosterone, estrogen, or progesterone, the idea is as these levels get up, increase in concentration, what is going to happen is they are going to shut off further stimulation. So they will have an inhibitory action on the anterior pituitary as well as the hypothalamus. So the idea is once we get enough hormones, then it gets shut off. Okay? And again, one thing to look at is where we can have dysfunctions. We can have a dysfunction up in the brain. We can have a a dysfunction in the for example, in the brain would be the hypothalamus and the pituitary. A dysfunction could occur in the gonads, in the testes or the ovaries, and we could also have possible dysfunction at the receptor levels of the tissues. Okay. Now, this chart, I don't want you to spend, I've got it in red, but I don't want you to spend much time on it. We sort of went over this a little bit in clinical med, and what I really want to put this chart in here for you to see is to just review or to emphasize that, you know, when we're looking at the things that are occurring and we're looking at the female's menstrual cycle, what we're going to see is that notice the time frame. So we start from theoretically 0 days up to 28 days, and most people use 28 days is what is considered a normal menstrual period. But you guys have been in practice long enough, and even if you weren't in practice, you probably are aware that there are various differences with regard to women. You know, if a woman is 29 days, there are some women that may be a 24-day cycle. There may be women that may be on a 35-day cycle, and that may be normal for them. Okay. The other thing, when we're looking at one of the reasons that we may look at these hormones in women is because frequently, if they have some problem, typically we're going to see it's a situation where that they are having problems with their period, where, for example, they may be having a very heavy period, a too frequent a period, or not having a period. And so this may be the chief complaint as to why they show up with regard to this. I am curious. So most of you that are in practice that are, you know, dealing with women, when you get a medical history, do you frequently ask information about their periods? Is that some information that you want to know? For example, if you give them the a questionnaire as a new patient coming in, so let's say it's what I thought is okay. So it's actually what I'm sort of thinking of is several of you do. Several of you may not need the particular info depending on the patients that you're on there, but some things that that comes up here is, which is what I typically see in other classes, is that some people, what happens is, sort of looking at Kirsten, your responses. One of the things that we do see sometimes is that clinicians and psychologists fit this category easily, is that they have pretty much a template of a questionnaire that they get. And that questionnaire basically has periods on it. But again, that may be information that may not be important to you. But, you know, frequently a lot of clinicians will want to know, and when I say clinicians, it's across the board there, is sometimes what we see is that may be an important piece of information. For example, as some of you have indicated, if a person is depressed, if a person has an issue about their period, maybe that's one of their chief complaints, or maybe the problem is they're fatigued or something like that. And one of the issues that one of you, let's see, pointed out, let's see. Yeah, Monica, you put it in there, is that somebody comes in with anemia and fatigue. One of the things with anemia is that we do see that people that are having heavy periods many times can develop an anemia. Depression can sometimes be associated with the cycle. So in some instances it comes up, some instances it doesn't. We typically see it with depression. Sometimes we have it when people get really manic sometimes. Sometimes anxiety disorder could be, or some of the issues with anxiety. For example, if the anxiety goes up, and part of the issue may be that the reason they're becoming really anxious is because maybe they've missed their period, or they're late with their period and they're concerned about pregnancy. I think one of the things that you will see when you get into the prescribing mode, if you're actually prescribing, I think you will, this is something that you may want to, that's going to be necessary for you to be more aware of, what their period, or if they're potentially getting pregnant, because some of the drugs that you guys that will be prescribing, you don't want to prescribe in a pregnant woman because of potential for, birth defects and other things there. But as we're going through the next few slides, one of the reason I wanted you to look at this this chart here is notice this is a good reference chart. So when we're looking at follicle stimulating hormone level or luteinizing hormone level, one of the things that's going to be important is going to be from a standpoint of where's the woman at in her cycle. Is it supposed to be elevated? Same thing when we get down here with some estrogen levels or progesterone levels. That will give us an idea of possibly whether it should be elevated or depressed. So that's going to be an important thing that we may need to know if we're going to look at these type of things. I'll mention this in a little bit later, but I want you to notice right here. Notice this this peak right here. That is going to be that's going to be an important thing, because one of the things is we expect luteinizing hormone to sort of spike. We don't expect the luteinizing hormone to stay up and stay elevated and be plateaued off. In fact, one of the things that may be an issue there if they're trying to get pregnant, luteinizing hormone may be it may be important that that they're not spiking, they're not getting this pulsatile release. The other thing is that people try to sometimes time when ovulation occurs, and the luteinizing hormone you're going to see is a test that we can use, or something that we're going to use that's a little bit better than, more accurate than body temperature. Okay? All right. You guys still bear with me because it's like I'm hunting all over. The one thing that we did have with the other collaborators, I got so used to looking exactly where my pointer was and so forth, and now it takes me a moment just to reorient here. Okay. Now, as I said earlier, one of the big things here, and again, getting back to when you're studying, is I don't want you to memorize that previous table. I want you to sort of find out where those, when the levels are increasing and decreasing. That's the main thing I want you to be aware of. Okay, so it's not an untypical situation. A woman comes in and she has amenorrhea. So what we're talking about with amenorrhea is basically, oh, I'm sorry, I didn't see your question. I'm having to get used to, Maribel, I'm having to get used to looking to the chat board differently. So sometimes people have suggested that the increase in or the alteration in the hormones could potentially stimulate mania. So whether it actually can or not, some people have tried to relate that to elevated testosterone and things like that. And I'm not sure that there's really good data that correlates it, but we do see occasionally, especially in women, is when they're having surges of their hormones, is they may be more emotional, and if they're bipolar, it could potentially be a trigger for the mania. That's it there. That's the main thing that people have come up with. It's not the excuse. I mean, I've gotten calls several years ago that, and some of you may be aware of it, is that in the premenstrual state, there have been potential lawsuits, or I should say lawsuits. There have been more so of people that have been tried to use the aspect of the hormonal changes that occur during the premenstrual period that may be, that has triggered someone to act irrationally and, for example, assaulted or killed someone. I don't know if you guys ever remember that. When PMS started coming out, it was sort of like the buzzword. And so a lot of women would say, during their premenstrual period, they tend to be more irritable. I mean, we've seen several people say that. So people sort of took that and have tried to use PMS to explain a lot of irrational behavior, which I think in many cases, especially with trying to justify behavior and everything, it was really sort of grasping at straws. But some people have tried to suggest that during the premenstrual period that there's more irritability, and with a bipolar patient, they may be more manic. I don't know if any of you guys have heard that. Just out of curiosity, has anybody seen any relationship or had anybody tried to relate the PMS period to increased areas of mania? So again, several years ago, there was this big thing where that pretty much what probably happened with this, which some clinicians will still occasionally, check. What probably happened is that there were some high profile cases, probably maybe 10, 15 years ago, that made the news where people were trying to excuse, again, murder or assault based upon that the person was, that it was not premeditated, that basically what happened was an individual's hormones surged, which had them develop irrational behavior, which was manic type behavior. So again, that was looked at a while back. I never saw any definitive data, but I still see sometimes people will look to see the case. Janelle, the thing is that when you say it was proven to be true with one, the juries or the judges or whoever was in charge accepted that with a couple of people, and it's sort of like what happens with Ambien when sleep driving popped up. What we found was anybody that was taking Ambien was, I got a lot of calls about sleep driving, DUIs on sleep driving, and what we would find is that sometimes the people would not have even taken the Ambien. They just were out drinking. We actually saw some students on campus, or not students on campus, people that lived in the Atlanta and even the Athens area, that they were typically young people. Some were students, some were just student age, would routinely take Ambien. So if they got pulled over for a DUI, and they would specifically request for a blood sample, and or ask the officers to take a blood, so they would, Ambien would show up in their system, and so they would then try to. That was their excuse, which the idea would be, well, I took Ambien and I slept and I was sleep driving, so therefore I'm not responsible for what occurred. So we did see that. So it was interesting there. Now, let's get back to the slide here for a minute. So amenorrhea is basically what we're looking at here is an absence or abnormal cessation of menses. And so one of the things that this typically comes in is going to be a situation where that the person is basically coming in. Maybe they're worried about them getting pregnant. A lot of times when women, their period changes, one of the things that happens they're concerned about, is it cancer? Is it something like that? So from that perspective, when we see this, one of the things that we may want to do is we may want to try to check it out. Now, I am not going to, so one of the things we want to do is we'll do a differential diagnosis. And part of that differential diagnosis will be, first of all, so let's talk about this from a standpoint if someone came in and some of you have some experience in this, but for example, what could be producing amenorrhea in a woman? Okay, so I think one of you, I can't remember which one of it was, basically mentioned you were looking at eating disorders. So one of the things that we find that eating disorders can affect somebody's period, and what we see is, for example, their follicle stimulating hormone goes down, so the D stands decrease. So 2 Ds is, it's more than just simply decreased. Luteinizing hormone goes down. If we have a reduction in FSH and LH, then sort of I want you to think about this. So a reduction in FSH and LH, what's going to happen with the estrogen levels? So if FSH and LH goes down or is decreased, what's going to happen with the estrogen levels? Think about that negative feedback. So one of the things that you would anticipate is that so basically if the FSH, which is follicle stimulating hormone, it stimulates the ovarian tissues to actually, when you get FSH, it stimulates release of estrogen. So if we get a decrease down, it's going to decrease the estrogen levels. Okay. So what we find is that with FSH, if FSH decreases, let's go back a couple of slides here. Let's say we went. Okay, go back to this first slide we started with. So let's just review this really quickly. So what we find is that the hypothalamus releases gonadotropin releasing hormone, which stimulates the pituitary to release gonadotropins. So that would be LH and FSH. Here's what we have here. So when they're released, they stimulate we're going to talk about the woman here. That's going to stimulate the ovaries to release estrogen and progesterone. Okay. When those get up, then that shuts the system off. So what we're going to see is basically that if we see a condition where that there's a decrease in, come on now, work with me. So if we see a decrease in FSH or LH, what we're going to see is there's going to be a reduced release of progesterone and estrogen. Okay. So if you look at this, there's several things that can occur that would result in amenorrhea. So one thing could be premature ovarian failure. So what happens here is the ovaries basically younger in the woman's life, basically the ovaries fail to function. So what we see is the FSH goes up and the LH goes up. See, it's very highly elevated. What they're trying to do is they're trying to stimulate. You got low estrogens. So what we're trying to see is we're trying to see a stimulation to try to get more estrogens produced. Okay. The prolactin is normal. The testosterone is normal. If there's a pituitary adenoma, so that would be a tumor up in the pituitary, then the pituitary is not going to be releasing gonadotropin. So there's going to be a decrease of FSH and LH. The prolactin, because of the tumor up there, will stimulate prolactin release. The testosterone stays normal. These are all in women that we're looking at. Let's skip the progestational agents. These are ones that basically, I can just explain it. So if we give a drug that is a progesterone, then we're elevating progesterone, which is going to decrease FSH, decrease LH, doesn't affect prolactin or testosterone. Person that's hypothyroid, basically, we don't have really much of effect. Sometimes the prolactin levels may be elevated a little bit, but they can often be normal. But the hypothyroidism, it really may just simply affect how the estrogen or the progesterone works on the tissues, but it's not going to really affect the hormonal aspect. But eating disorders, we see decreases in FSH and LH. The prolactin tends to be normal. The testosterone tends to be normal. We have a syndrome, we'll mention it in a minute, which is polycystic ovarian syndrome. Typically, the LH levels are increased. The FSH levels are usually normal or slightly decreased. The prolactin levels are sort of normal or could be slightly elevated, but we tend to see some elevated of testosterone. Those women develop some hirsutism and things like that, which can be problematic there. And then we won't worry about CAH. That's a congenital condition there. Okay. So what I want you to do is I'm not going to ask you on the test to basically, I'm not going to say you would expect to see with PCOS what effects on the hormones. I'm not going to ask you that on the test. But what I do want you to do is maybe when we break for lunch, is that what I'd like for you to do is to pretty much look at, let's see if this is going to. Again, you guys bear with me. I'm having to get used to this. There we go. Well, I thought I had it. There we go. No. All right, so what I'd like you to do is maybe look at the premature ovarian failure. That's what I want. I'm going to circle a couple of them here. Yeah, there. So I'd like for you to maybe look at the premature ovarian failure, the pituitary adenoma, the eating disorders, and PCOS, is to look and see if you, by looking at what happens with FSH and LH, what I'd like for you to do is to see what would happen. Let me see, this is the easiest way to do it. What would happen with the estrogen and estrogen progesterone, okay? So with premature ovarian failure, let me just put it on the mesh here. So here's, I'm going to just put this, what happens to estrogen we could just say estrogen, so we won't have to worry about that. With POF, premature ovarian failure, the eating disorders, and PCOS. So I just want to look at it, you know, look at this table and see if it just, you know, if it makes sense, okay? There we go. All right. My mouse is not responding here. Give me a moment. All right, so let's go to the next slide there. All right, so let's take a look at what happens with hyperprolactinemia. So one of the things, hyperprolactinemia, we do know is highly elevated or extremely elevated prolactin levels. We got the prolactin, and so that's what the hyperprolactinemia is. But what the patient normally presents with would be galactorrhea, okay? Now, there may be some other symptoms, but probably most women that come in that we're going to have a, they're going to have this problem is basically going to be, those individuals are going to probably present with the galactorrhea. Does anybody know of any other symptom that may, I mean, they could present with plenty of other systems, but one of the big things that's going to happen is they may have breast tenderness. We may see that they have, that they may be complaining of, typically is they're going to complain of excessive milk production, okay? Sometimes they may be developing infections from where the milk stagnates in the breast and becomes infectious. We talked a little bit about that. But many of them will come in, and what they'll complain about, like sometimes they can't, the entire front of their shirts or blouses is drenched, and it makes it very difficult for them to go out in public, things like that. So again, on these values for labs, I'm not wanting you to memorize these lab values. You can look those up, and I should have said this last week, last time we met. Don't know if I did, but frequently, you know, when you get lab values from a you know, from the lab or from the hospital, they will have the normal values there. Many times they will be marked as to whether they are high or low, and they'll usually have an asterisk, or sometimes they may have an H or an L or an arrow next to them or something like that, or have some indication that they're outside the range. And again, even if it's like, let's say the range was, you know, 5 to 50. If it's at 51, they would be marked. And the 51, most likely for whatever value we're looking at, would probably mean, okay, it's elevated, but and maybe I want to watch it and see if there's something going on, but that's not going to be typically a huge alarm for that. So what typically is presented is basically with galactorrhea. When you see that, you're more likely than not to think, okay, we've got a problem here to let's check the prolactin levels. That would be one of the first things. Things that can cause this. One of the things that you first want to look at, because some of the drugs, the antipsychotics, is medications can frequently increase prolactin levels. Antipsychotics are a good example. We see oral contraceptives. We see the antipsychotics, as I've said, antidepressants. There are some antidepressants that can do this. And there's a few antihypertensives, H2 blockers in particular, the drugs over the counter, such as the one you worry about the most is a drug called cimetidine, if you guys remember that one. Cimetidine is you remember what the trade name for that was? That was Tagamet. Okay, cimetidine actually has its structure is very similar to progesterone, and most of the other H2 blockers we don't see a problem with, but cimetidine could do this. Typically, it's going to be in higher levels. The other thing you will find out next semester is when we talk about cimetidine or H2 blockers, you'll find out that it is one of the drugs that can cause a lot of drug interactions through the interfering with cytochrome P3,4A. So these some of the opiates can do this. So one of the things we come in here with galactorrhea, the first thing we want to check on would be the medication history to see if there's any drugs that the person may be taking, and especially if they just recently started those drugs, or possibly if they had another drug added on, which may have had a drug interaction to increase it. The other thing that people frequently will complain about is, or may come in, as a woman may come in, is not only galactorrhea, but she may also her period may have changed. She may have developed amenorrhea, and in fact, that's one of the basis. You guys know that that one form of birth control that people sometimes practice is when the idea is if they're breastfeeding, basically that would prevent that's going to prevent pregnancy. That is always not the best way, okay? Because people, while they are breastfeeding, have gotten pregnant. And some people believe it's because, especially in very civilized countries, that when women breastfeed, they breastfeed on a schedule. Whereas in other countries, in other areas, the women may feed on demand. And by feeding on demand, it seems to be a better way of suppressing this. But basically, elevated prolactin levels can affect estrogen levels and affect the period. So again, here's what we would do is we would see symptoms, again, taking a lab or taking symptoms and using the lab to give you a totality of evidence that comes into play here. So I've got galactorrhea, possibly altered period, and by doing that, basically, or seeing that, I would do to measure prolactin. Then with the elevated prolactinemia, the elevated prolactin levels, then basically what I'd want to do is find out why is that occurring. Is it a drug she's taking? Is it a situation with regard to maybe a pituitary tumor or something like that? For example, there can be a prolactinoma, which is a tumor up in the pituitary gland. Okay, so let me cover this slide and then we'll take a break. This will be our first break. All right, so ovarian failure. One of the things we see is that one of the natural consequences of aging is basically menopause. And menopause we often refer to as, we many times will refer to menopause as being, as actually a physiological ovarian failure, that with age the ovaries have failed. And so what we end up with ovarian failure, remember on the slide, a couple slides earlier, we had premature ovarian failure. That would be a condition that would be abnormal. So what we have with ovarian failure is persistent estrogen deficiency. and the FSH goes up. The reason this is when the estrogen goes down, the FSH is trying to drive or to try to stimulate the ovaries to basically produce more estrogen. And when we have ovarian failure, the ovaries have failed, so therefore we're not going to have that occurred. Typically, what we're going to see is that if we measure FSH levels, we're going to see that they typically are in the range that we would expect to see in a woman in menopause. So one of the things that we can see sometimes is that, again, this is the reason why we have to take multiple levels, is that as the ovaries are beginning to fail or starting to fail, even with menopause, basically what's going to happen is the FSH levels can fluctuate. So just taking a single FSH value really doesn't give us a lot of information because of this potential for this fluctuation. So what you would look at is typically we're going to see that the FSH would fall. Again, you're not going to need to know these values, but the FSH would be between 40 and 250. Luteinizing hormone would be greater than 75. The estradiol would be less than 1.5, and the progesterone would be between 10 and 22. Those are typical values that we see for menopausal women, and then you would then compare them to normals. But again, when we're looking at this, one of the things that we might do with these FSH levels is sometimes when women start hitting the age of menopause, I don't know if you've heard this, but we see, Maribel, I'll get your question in just a second. I just happened to see it. One of the things that we find is some women start feeling moody, start showing some symptoms that they think they're going through menopause, say in their 50s, and they just assume that's occurring. And then they go through another episode, maybe in their mid or late 50s, maybe even their 60s. And so it's not uncommon for sometimes women to have thought they've gone through menopause. And so one of the things that we may do is we may want to make these FSH measurements to see if they are actually have gone into menopause. Because we do see women that show some symptoms of menopause and think they've gone through menopause, and then a little later on in life, it's like, because I've had women have asked when I've given seminars and things like that, they want to know is like, can you go through 3 or 4 menopauses? And so the FSH values is predictive for that. These FSH values are also something we want to look at if we're expecting premature ovarian failure. And again, what do you think is the main reason that would drive a woman in to see a physician with regard to that was developing premature ovarian failure? There's really a couple of things there. One reason frequent reason they may show up is they are, they can get hot flushes. Yep, that's one thing. Thinking something else. Weight, smoking. Actually, a couple of things is going to be their period changes or they can't get pregnant. That's another thing that occurs there. Okay. So Janelle, what you do is that you're looking, the FSH is not the only thing that you're looking at. So you would look at their period and the FSH levels. You'd be getting multiple things there, but the FSH would add to that part of that diagnosis. Maribel, you had asked with regard to where's it at? Oh, to the estrogen. So if the prolactin is high, what can happen is the prolactin can the prolactin can inhibit the estrogen levels. So the estrogen levels may go down. Okay. But again, one of the things that makes this so difficult is that trying to take one lab value, even if you're taking multiple, like for example, if you're getting one blood sample and you're pulling FSH, LH, estradiol, and progesterone, that gives you a better picture than just looking at one of these. But many times we need to take multiple samples. So the reason for that is to try to figure out what happens. Sometimes during these failures, and one of the things that can happen, and I've seen this occur, is sometimes that somebody's having a lot of mood disorders and things like that. We see a lot of people trying to figure out why that they're having difficulty getting pregnant, and we see people having a lot of mood disorders. And sometimes we see sometimes OBGYNs particularly will want to look at these because they may be trying to figure out why someone's not getting pregnant, or why somebody's having difficulty getting pregnant, or why somebody's having their periods are fluctuating a lot. And the other thing is that sometimes what can happen sometimes is that we do see that when individuals' periods are fluctuating, that we do see a lot of fluctuation of moods. And sometimes by getting people on oral contraceptives, we're not really using them as oral contraceptives. We're using them more for hormonal therapy. We can, one of the big things that oral contraceptives can do by regulating the amount of estrogen or progesterone, whatever the particular product is, and sometimes it's finding the right product, that we can stabilize the period, and we can actually get people that are feeling better, both with their mood as well as their period. So those are some things that can come up. Okay, I have to get used to this new chat board because sometimes all it does is it really, sometimes if some of you have asked a question or something like that, is when you put something else in, in fact, I was looking at I thought somebody had asked a question that about the estrogen, POF, and eating disorders that I had put out to y'all, and I thought that was interesting. Somebody had that question, but that was me that wrote it. So I have to get used to that. So this seems to be going a little bit smoother. I feel a little bit more comfortable with it as I'm getting used to using the things here. I hope the rest of you, it's easier to follow. Let's take our first break. And Arnold, what I did was I just put my cursor on the top of the, let's see, is the chat thing here? Let's see. Let me move it down this way. I've been moving it over there. So is it covering the screen that I'm putting up there? Yeah, I'm going to try to get mine. If you go exit full screen mode, it goes to the side. Let's see if I go. Okay. All right. So let's see. Let me get back. So let's take a break. And those three questions that I gave you, go back to the previous slide where we had this one here. So those questions is, what would happen to the estrogen levels? Just work through that and take a minute to do that. So let's come back at, I've got right at 10 after the hour. Let's come back at 25 after the hour. That would give you guys about 15 minutes for a break and a little bit of doing this, okay? It could be that. All right. So, Aiden, I don't know if you want to stop recording for the break or if you want to let it just keep running. That'll be up to you. And I'll try to remember. In fact, I'm going to put a note on my computer.
I'll pause it, doctor.
Okay. All right. So let's come back at 25 after the hour, and then we'll continue on. Make sure you mute your mics when you come back on.
Sure.
We're able to figure this out, but for example, I think with the premature ovarian failure, so if you got elevated FSH, and actually some of you thought through this too. So what happens with elevated FSH and LH is basically it's going to try to increase the estrogen levels, but as I think Angela, you mentioned into it, this can actually sort of quote burn out the ovaries. Is you can only stimulate them so much, and to try to get that out. So you can see where it would go up, but it can reach a point where that it's just overstimulation and can actually just overdrive an organ sometimes. So with premature ovarian failure, what we should see is with the elevated FSH and LH, you should see an increase in estrogens. With the eating disorders, when those are decreased, what you may see is that you would have a decreased, so estrogen levels would go down because you're not releasing it. with PCOS, the elevated LH would increase the estrogens. And then where you run into some problems with PCOS is, notice on the FSH and the LH is the FSH can be normal, or it can actually decrease, and the LH can stimulate, can be elevated. So then you can start getting some various things there that occurs. But again, one of the biggest problems is that you can get, although that with the gonadotropins going up, they are stimulating the ovaries, but the ovaries only have so much estrogen that they can put out. And so you can eventually, quote, the term burnout sometimes actually is a good term that applies there. So you guys thought through that pretty well. That was pretty good. All right, let's go back and let's get back to the, actually we missed a slide, I think, or no, this is the slide we're on here. Yeah, so we talked about ovarian failure. So this sort of segues into the with menopause, which is actually considered a physiological ovarian failure. So what's going to happen here is with the physiological ovarian failure is basically with menopause, the ovaries have just basically gotten too old. And so one of the things that we see is we start getting increased secretion of LH, luteinizing hormone. And although luteinizing hormone can have an effect on, has an effect on releasing estrogen and progesterone, but one of the things that happens is that when the ovaries are failing and you're not getting, the LH is still there. So one of the things that happens is that luteinizing hormone can actually cause the secretion of androgens. And with the androgens, what's going to happen is now during in that postmenopausal stage, what we find is the testosterone and there's another androgen called androstenedione. So these are androgens, these are the male hormones. So this actually increases the secretion of the androgens. So what do you think happens with the increasing of the androgens? What type of symptomology do you see in postmenopausal women that would be suggested with regard to increased androgens? So you can have mood. One of the big things is increased hair. That's called hirsutism, which I've got a slide on a little bit earlier. Those are some of the most common thing is we see some mood disorders, and we see some a degree of masculinization. Typically, is more with regard to, for example, increased growth of hair. The other thing that happens is there is another estrogen. We have several different forms of estrogen that are made in their body. I think when we talked about clinical medicine, we touched on some of those, but we will touch on these more in pharmacology. But what you see is in the postmenopausal women, in the younger women, we used to see a lot of estradiol. And in the postmenopausal women, we get a slightly different form of estrogen, which is estrone, and that becomes the predominant estrogen. And the thing with estrone is that basically it's one of the estrogens that tends to put on weight. So a lot of postmenopausal women start, as we get older in general, both males and females, we have more body weight and less lean mass weight. And in women, women have more subcutaneous fat anyway, but also you get fluid retention. And basically, what you're going to see is that postmenopausal women may put on weight based upon this production of the estrone. Now, the other thing that's sort of cruel is that the androstenedione, which is the androgen, so we get less testosterone, but we still get some androstenedione. So what happens is this androstenedione that is produced, basically what will occur is, this keeps changing slides, this androstenedione will actually be converted to estrone in adipose tissue. So as you start putting on weight, and we see this happening in males too, is that we find that when people put on weight, the adipose tissue can actually generate estrogen type compounds. So the androstenedione, so the fat cells can actually produce estrogen type compounds, but also what happens is androstenedione, as it's formed and it goes into the fat, basically it gets converted to estrone, so that's another source of estrone. Now, we talked about this a little bit, and I didn't highlight this slide for you guys to know too much on, or at anything on, but this polycystic ovary syndrome, sometimes it's called, typically we abbreviate it PCOS, and I've heard it called more frequently polycystic ovarian syndrome. So what happens here is the ovaries actually will develop several cysts in them. And we get a state in these women in which it's a hyperandrogenic state. And a hyperandrogenic state means that basically your body is producing more testosterone and androgens. So, a lot of people think of the testosterone and androgens, being, opposed to the estrogen and progesterones. But we get the hyperandrogenic and ovulatory state. These women also tend to put on weight, which we get more conversion and more production. Even though the estrogens are there, they put on weight, but they still are getting more androgens. And as they make more androgens, some of it gets converted to estrone. So you really have any of y'all dealt with, has any of y'all had any patients that are PCOS? Just out of curiosity. Several. Kirsten, and I see Geraldine, you've done, so several of you have. So with those of you that have dealt with these patients, or know them as friends, tell me what characteristics you see of these patients or friends. Many of them are overweight, correct? What else? So we see the masculinization in many ways with the hirsutism, which is the hyperandrogenic. The thinning hair can occur. Body shape and hair growth, difficulty losing weight, okay. Definitely difficulties getting pregnant, because when you have which brings us to an issue with regard to the hyperandrogenic syndrome, is that a lot of people sometimes, when you're thinking of this, they're thinking in older women, but we have younger women. What's the youngest patients that y'all have dealt with, or what range of age have you dealt with these PCOS women? Young adult, exactly. A lot of individuals, when they see PCOS or hear of it, it's interesting, is a lot of them are thinking of more closer to, maybe just premenopausal or so, but actually a lot of these women are fairly young. What we find is there's a lot of things that you deal with. One is that you can deal with situations of that they can't get pregnant. They sometimes have some body dysmorphic issues. They don't feel because they put on weight. What about their periods? Are the periods regular? Yeah, exactly. Joy, you sort of covered it exactly. Jason, that may just be a conversation starter next time when you're at a social thing. Is like, I understand all of y'all have PCOS, just sort of, tell me, we're talking about that in class, so whatever. So we do see that they do present with a lot of irregular periods, and I like the comment I think Joy you said was just a mess, because a lot of them, it's like the periods can vary between how heavy they are, how light they are. The other issue is is coming into a lot of different issues of like irritable, don't feel good, fatigued. They are very susceptible to getting diabetes is another thing. So you see a lot of these women that develop this polycystic ovarian syndrome, it's very, very difficult to deal. Now, Kirsten, you bring up an interesting thing, is that there's a whole new issue that's coming in with when we start looking at these the gender neutral patients and transgender and so forth, because some things, this is an interesting thing you made, Kirsten, is that here's a person that actually embraces the dichotomy. And so that sometimes some of these symptoms what they may want is one side versus the other, or more of one versus the other. So it creates a whole new issue in dealing with these patients. There's been a few articles that I've seen over the last few months about meeting the needs of these gender neutral and so forth. So that creates it. Jason, your question is very good. Is the PCOS is that the weight gain contributes to it, but there may be it's not quite sure if whether the testosterone levels or the androgenic levels can contribute to it, but definitely the weight adds to this, and also I'm sure that some of the changes that occur due to the androgenic stimulation probably interfere with the proper use of insulin by the body. So there is one of the things that we used to see when I was doing mainly cardiovascular is the PCOS women were sort of a population that diabetologists like to study because they did develop a high degree of diabetes and there were certain unique things. So they are more susceptible to some of these cardiovascular issues that occur. You know, one of the things that can happen is with reduction of the estrogenic component, one of the issues that can happen is that we see they may be more susceptible to atherosclerosis. So it could be not so much of the androgenic component as much it is as a suppression of the estrogenic component. So one of the things that will occur is these polycysts that develop in the ovaries can grow. They can be painful. They can, they may, as they grow, press against the normal tissue and affect, you know, other parts of the ovaries, and they can actually develop, you know, some degradation of the ovaries. So what we see in these patients, if we looked at the hormonal lab values, typically we see it's a hyperandrogenic state, as indicated by several of the things that we've identified. And so that's typically associated with an elevated testosterone. Sometimes we see an elevated LH, or at least that the LH is being stimulated more than the FSH. So we do see the LH to FSH ratio is greater than like 3 to 1. The other thing that's interesting is that we don't have a sustained release of LH, but what we do see is an increased LH pulse frequency. So that can mess up ovulation, and the rhythm that LH is being secreted, diurnal rhythm, is off. So there's a lot of issues associated, hormonal issues associated with this, which gets back to I still go back to you know, that what Joy, your term was a mess, because there's a lot of things happen and there's a lot of things happening over time. So a lot of things, what we do see is typically elevated testosterone, and that's why it is classically called an elevated or a hyperandrogenic state. But typically, a lot of these women have very difficult time getting pregnant, mainly because they're in an anovulatory state. And then when they do have their periods, and this is because of maybe these fluctuating LH levels, when they do have their periods, they can be very heavy and they're very unpredictable. So, and then they have a plethora of health problems. And the difficulty with this is basically trying to get, you know, with so many things going on, trying to get this under control. So these women are sometimes very difficult to treat because of the dynamic situation that they're undergoing. So this segues into a state where that we can have what is called a hyperandrogenic state. Now, the PCOS is a form of that. So that's but we can also have individuals that don't have PCOS, but have elevated androgens. Typically, what we're going to see is that the testosterone is elevated. We will see that there's other steroids, androgenic steroids, like one is known as DHEAS. Those are elevated. And sometimes this is due to a birth situation. We have a condition called congenital hyperplasia. And so what's happening here is that they are producing, they look at an enzyme or a compound, 17-alpha hydroxyprogesterone, to determine if it's one of these congenital hyperplasias. But sometimes we have individuals, one of the first things, if someone is showing hyperandrogenism, is one of the first things that we want to look at or check out is we want to find out if they are basically, taking steroids or androgens. After that, we may try to rule out other things, which is, potential tumors or things like that that could account for this. And so again, many of the symptoms that you described for PCOS, the hirsutism, the thinning hair, those type of things, you see more masculinization. As one person described it, in males, it's more maleness that can occur. Now, this hyperandrogenism can also present, although the elevated testosterone and everything like that, this can also present with some issues such as decreased libido, decreased erectile dysfunction. So actually some negative things can happen which seem to go against this. And the reason for it is, in one instance, it may be that several of these androgens may be being converted to estrogen. This is why, for example, weightlifters that are juicing on steroids, sometimes they will develop gynecomastia because the androgens actually get converted to estrogen or estrogen type compounds. So there's a number of things that can occur that sometimes may be somewhat counterintuitive to some people, like decreased libido. We also see, in fact, I had to do a talk for judges about 15 years ago, is a lot of people think that some sex offenders have hyperandrogenism, and therefore they want to, there's been discussions of both physical and chemical castration. The idea of by castrating them, they would decrease their testosterone levels. And there's, the chemical castration is going to somehow, depending on which agent you use, would inhibit the formation of either the testosterone or the other androgens. So, but the hyperandrogenism primary diagnosis is going to be that there's an elevated testosterone or some other androgenic component. All right, so here's our first question embedded. So we've sort of talked about it before, so you guys should get it. So if you have decreased FSH levels, what would that do to estrogen levels? So you guys can just answer on the chat board. And you are correct. So as we talked about with these other conditions, the follicle stimulating hormone typically is going to stimulate the release of gonadotrope, or the gonadal hormones, which would include estrogen. Okay. Many times, I don't know how many times you guys will actually see someone come in with a complaint of hirsutism. Talking to the other cohorts and some of the people that I've taught at Farley Dickinson, I've gotten 2 or 3 of the students that have said that a patient has complained, or one of the concerns has been, a female patient has been hirsutism. And these people typically may have some sort of body dysmorphic issues or self-esteem issues. And so that has come into, let me go back to Maribel. So Maribel, so one of the things that can happen is with testosterone, and we will talk about testosterone a little bit because of hypogonadism. But the issue becomes is that there are people that when they get high testosterone levels, that a lot of people think if I keep juicing up, keep giving more, taking more testosterone, that I'm going to become more masculine, more muscular, more increased libido, as well as increased sex drive, as well as not have any problems with erectile dysfunction. We can see that at high testosterone levels, and what is high may vary between individuals, because we can see individuals that, for example, are being given testosterone, that we do see an increase in sex drive. We do see an increase in or decrease in erectile dysfunction type things. But there are some individuals when they start getting the high testosterone, get just the opposite. The explanation for that has been that as you increase the testosterone, that it may be negative feedback shutting down everything else. Some people suggest it could be that very, very high testosterone, that the receptors downregulate, which could happen. Some people suggest it's the high levels of testosterone, you get more estrogen, which may do it. But we can see that we can see that there are people that, although they're taking it to increase their sex drive and increase their, any dysfunction, get rid of any dysfunction, that literally it has the opposite effect. So you can see that. And Joy, what you're saying there is that we've seen individuals that have basically, they've pretty much wiped their testes out or their ways that they produce it. So it can go both ways. But see, what sometimes happens is we've seen individuals that they start taking the testosterone expecting to increase their sex drive and increase or decrease their sexual erectile dysfunction. And so it starts being negative. So they keep trying to increase the dose. But a lot of people think one of the things that comes about is a lot of people think that the testosterone is going to really, really increase their sex drive. And in fact, a lot of individuals that have, rapists and things like that, a lot of people have attributed to, and we have seen, I've been involved with some cases where individuals literally, the idea is that they have been involved in date rapes and things like that, and they have been taking things, or people have suggested that they have been taking high levels of androgens. So it can vary. We can see it go both ways. As why it is specifically occurs where it may depend on the individual, but there's several explanations as to why it occurs. What I typically tell the students is that taking testosterone, especially our pharmacy students who may be dispensing, or maybe a patient may be talking to the pharmacist about, when they get a androgenic compound or a testosterone. There's a number of drugs that came out to increase testosterone. Those decreased somewhat after there was some lawsuits about creating heart attacks. We're going to talk about that in a little bit. But the thing about it is that it's very difficult sometimes to predict. You really have to watch what's happening. But a lot of times, one of the concerns is when you're giving exogenous testosterone, that it may be shutting down the internal, basically as a negative feedback. And so that has been one thing that could occur. So, okay. So hirsutism, getting back to what I was saying, is that we do have individuals that basically what they, show up with is excess hair that is present in their, typically with the, in women, they were going to see it keeps jumping. What we see is excess hair. Typically with the excess hair is we are seeing that on the face as women develop, hair around their chin, on their, may even sometimes get a beard. And when we refer to an androgen-dependent area of a woman's body, basically where males would typically grow hair, such as with a beard, mustache, and things like that, that's where we expect it. The hirsutism can also be on the arms, even the legs, under the armpits. So those are the areas that we typically see it, maybe even in the pubic area. And typically when we see hirsutism, that is indicative of increased circulating androgens. So that could occur due to endogenous stimulation, so that your body is producing more androgens. It could also be because of the decrease in estrogen. One of the things that happens when you decrease in estrogen, the balance sort of changes. So those are things that could occur. It could be due to exogenous. So in other words, they're taking a pharmaceutical compound there. In males, the testes are the primary place that androgens are produced. But in females, females don't have testes, but what we do see testosterone can be produced in females and is produced. The major source of testosterone levels is in the ovary. And when we get back to that polycystic ovarian syndrome, one of the things may happen is that ovary may be actually accounting for some of the testosterone that's there. Now, another sort of interesting thing is about this condition, or about this hirsutism, or the thing that occurs, is one of the things that happens is that if you think back when we talked about diabetes last semester, if you think back, one of the things is that your muscles are one of the major sources that uses insulin. Okay, so insulin is very important for driving sugar into that. So when we see sometimes and this is part of the diabetes issue occurs, is in PCOS. But if we do get an elevated insulin, then one of the things that happens is that the protein that carries these hormones around, particularly testosterone, that's referred to as sex hormone binding globulin, which is SHBG. So when you get an elevated insulin level, that decreases the SHBG. And what that means is that you've got more free testosterone. It's sort of a mechanism of, like, for example, when you're elevating insulin, typically is when you have more muscle, is that you're going to have to elevate the insulin to try to push it through. But one of the things that happens is that decreases the serum sex hormone binding globulin, which is carrying some in your body. You've got normally testosterone and sex hormone binding globulin. So you've got testosterone bound to that, and you've also got some free testosterone. It's the free testosterone that leaves the blood vessels, leaves the blood, and goes into the tissues. So one of the things that can happen is we can see that if there's a change in insulin, that can elevate the amount of free testosterone, which means there's more testosterone that is going to be present to go to the muscles and the other tissues. All right, let's see. Still getting sort of a little bit used to this. There we go. All right. Now, let's cover 2 slides, and I'm going to give you guys a short break. So infertility, one of the big reasons that women, come to see gynecologists, their primary practitioner. I'm going to guarantee you, if you're dealing with somebody that's dealing with depression, anxiety, and things like that, you're going to have some women that are dealing with fertility issues. Just out of curiosity, have any of you deal with patients on a regular basis that fertility issues actually come up? Not necessarily for you to treat it, but yeah, exactly. And that's pretty much what I thought. So even though it's not on a regular basis, it's something you're going to see. All right. So one of the issues that comes into play is that when people are trying to get pregnant, and especially in today's world where that many of the women go on birth control or use some form of birth control, one of the things is that people are using the plan, and when they're ready to have children, it's pretty much so Eddie, you basically cover both male and female that have this, which is an interesting thing, because a lot of times with fertility issues is what you see is that I've seen this over my career, is that we've seen many, many women that go through all this elaborate testing. And one of the things that happens is that the male is not being tested at the very beginning. And the male test is fairly easily, pretty much they get a semen sample and they determine if there's enough sperm count, if there is if the sperm are normal, and so forth. But we've seen women go through all this different testing and get all these hormone measurements and everything, and the male has never been tested, and several times it's been the male. So one of the things is, when people in today's society in particular, we have individuals that basically it's like everything's planned. It's like, okay, I'm ready for I'm ready to have my child, and I'm planning on having it in the summer. I mean, I hear that all the time. I hear that a lot from the students is, well, I'm finishing pharmacy school, and what we're going to do is that I'm finishing pharmacy school, and take the PCAT or take the board exam, and then we're going to get pregnant next year, or I'm going to work 1 year and we're going to get pregnant the following summer. And you're going, good luck on that. If that's what you want. So anyway, people, because of our technology, because of we do have, birth control pills, which can let people choose when they have it. And then people decide they're going to get pregnant. So then they want to plan exactly when it's there. In fact, you find today that a lot of people want to know the sex of the baby. I've even seen individuals where that in working with their gynecologist, they pick the exact day when the baby's going to be born by a C-section, or when labor is going to be induced, and so forth. So one of the things for years, people, especially when they're trying to get pregnant, is the idea has been to try to determine when is the optimum time to have sex. And the optimum time is based upon when the woman has ovulation. So what people used to use, and they still use it today, is they do a basal body temperature charting. So what the woman does is basically take her temperature and basically documents when you have the LH spike, is basically you see a slight surge of temperature. Now, I asked this to some pharmacy students taking a course with me the other day, and I asked them, specifically, this is getting to something which sort of what you're talking about, Jason, is number one, when you say you look for the temperature spike. Well, if you talk to some lay people, a temperature spike, they may be thinking 2 to 5 degrees temperature spike. And that's not what it is. It is less than a degree, okay? Which means a couple of things. Number one is, first, you have to have a specific thermometer to do this. So you can't just get, a run-of-the-mill thermometer, because it's not quite as accurate, okay? Number two is, if you think about it, if you get up in the morning and go to the bathroom, or you get up in the morning and walk over to let the cat out or the dog out or something, and then come back and take your temperature, that simple amount of movement could be enough to show, to show a slight spike. So the problem is that there are some issues with it, plus that it's very tedious to be, taking your temperature. And it's, some of the people that have used this, it's sort of like, my temperature's up, we got to have sex right now. So what we've seen is a better method is now we're using urinary luteinizing hormone prediction kits, okay? What that does, what you're actually looking for, that spike occurs when luteinizing hormone is released. And what you want is a spike. You want it's released. And so the idea is that when the LH surge occurs, that is going to occur 14 to 48 hours before ovulation. So the idea here is that when the temperature spikes, then the next 48 hours is the optimal time to have sex, because that is when the ovulation is occurring. And so it's more likely to get pregnant. That LH surge is more difficult to pick up with the body temperature, but is fairly good to pick up with the urinary LH. And in fact, it probably gives us the greatest accuracy of predicting ovulation. Now, one of the things that can happen is that sometimes somebody is doing that, and they may still not be getting pregnant. So one of the things that may happen is that we will look at the progesterone level. So the single mid-luteal progesterone level, we measure that around midpoint between ovulation and the start of the next period. And that will, so what we do is we use the LH, and then we will take a progesterone level. That will tell us, that sort of is a confirmation that we have had normal ovulation. So that is, we use that as sort of a confirmation test. If people aren't getting pregnant, one of the first, in women, what we're looking for is pretty much, we want to see if there's some ovulatory dysfunction. So we go back to, you remember that chart that we said all these different things? We look at FSH, LH, testosterone, and prolactin. and that will tell us potentially if there is some ovulatory dysfunction. Okay, again, we may have to take several measurements, but we do see that. So, Janelle, what you're mentioning there is, I was just reading your comment, Jason. So, Janelle, one of the things that you see is that sometimes what happens is people get so caught up, or this is what a lot of people theorize, and I sort of feel the same way, is they get so anxious over trying to conceive or having a child or get pregnant that basically the stress can affect the period. And so what happens is they adopt a child, and so now the pressure, but they're still trying to have a child of their own. But once they adopt it, the pressure of trying to conceive goes off and they get pregnant. And I think that's part of that can occur there. So that's some things that will that can come into play there too. Let's see, I wanted to cover, I think, one more slide. There we go. Let's cover the next two slides and answer the question, then we'll take a break. So FSH, we've talked about it. That's regulated by gonadotropin-releasing hormone. It's also regulated by estrogen and progesterone from a negative feedback. And so by measuring FSH, that can tell us if there is either primary or secondary gonadal deficiency. We can determine by measuring FSH, is the pituitary causing release of FSH, or if it's not, so we can determine if it's pituitary or if it's somewhere else, okay? When measuring this, especially in women, we've got to determine when was their last menstrual period, and that's particularly important when we are trying to interpret what's going on. So that's a reason why we want to know when their last period was. And then with LH, that's the other gonadotropin, and it's also regulated by gonadotropin. It affects estrogen and progesterone. And what we do see is, like I said, it's a mid-cycle surge of luteinizing hormone. So it's a surge or a spike of LH. If the person maintains a constant level of luteinizing hormone, in other words, we don't see that spike, then they're not going to get pregnant. In fact, what you actually see is that by keeping a constant LH, it will actually suppress ovulation. Again, it's important that we look at when their period was. So our question is, going back, hirsutism is associated or would be associated with increased testosterone, decreased estrogen, increased estradiol A and B. So the answer is D. Basically, the increased testosterone typically is the most common for it, but it can occur sometimes when there is a decreased estrogen. Usually the decreased estrogen, we tend to have some increased testosterone, but that's what the answer is. Correct answer is D, which is increased testosterone and decreased estrogen. So I guess the way it's worded here, you could throw you off, is because you could have increased testosterone alone and normal estrogens. You could have decreased estrogen and increased testosterone, which would do it, or even decreased estrogen could do it. Okay. All right. Let's see. It is, let's give you guys a break. Let's come back at 20 after the hour. A Word document with about 4 links. If you will post that for them to take a look at lunch, that'd be great. Okay. All right. So let's see. Move on to our next question here. There we go. So progesterone is another one of these hormones that basically can be measured. What progesterone does, and actually one of the videos you guys have got for lunch is a very nice video that shows you a 3D animation of the menstrual period, and there's some videos with regard to situations with PCOS and so forth. So probably about 20 minutes total for the 4 videos, if that. So the big thing with progesterone is that progesterone is the body produces that to actually prepare the uterus for pregnancy, and it helps to maintain the uterus for pregnancy. If the person's not pregnant, then basically the progesterone levels go down. So one of the things is that if you measure progesterone on day 21, assuming a 28-day cycle, that actually gives us one of the best ways of determining whether whether ovulation has occurred. So that's another thing that may occur again. These type of tests are being used to determine whether the woman is actually ovulating normally. And the idea here is if the ovulation process is working, that's just another little tick that we can get off, and to try to determine what's wrong. If she's ovulating normally, then the next thing would be, are the other things to consider is obviously the male, which we talked about earlier, which probably should have been considered very early on. But then we need to look to see if the eggs are viable and things like that. So there's other things. So what we typically see is that, as you will be able to see in the video, that typically the ovarian or the ovary that is producing progesterone tends to be very low during the first phase, because basically the progesterone comes into play in the luteal phase, where the uterus is being prepared to receive a fertilized egg and to grow. But what we see is that from about week 9 of pregnancy up to about 32, we see there's an increase in the progesterone levels. And so again, this is one of the tests that we can look at to sort of monitor everything. We mentioned prolactin. We talked about hyperprolactinemia, but prolactin would be another. For example, one of the things that may come up is if the woman is a pituitary hormone. And what we find, this gets back to the answer to a question that was asked earlier today, which is when at puberty, what's going to happen is that the estrogen levels are increasing. And when the estrogen levels are increasing, that actually increases the production of prolactin in females. And then the prolactin is going to be involved in stimulating breast growth and also stimulating other hormone things. We see it peak early in the morning. Typically, we want to measure the samples 3 to 4 hours after awakening. Most of these hormones, as you can see, a lot of times in the labs, we want to take them in the morning. And but there are times when some of these hormones, if they peak at different times, that we may specifically ask the patient to come in to at a specific time. But a lot of these, if we take them early in the mornings, we can get a good assessment there. But so the increased estrogen increases prolactin, and then what's going to happen is as the prolactin levels go up, they're going to suppress the estrogen. So getting back to the question, what happens is when prolactins go up, they will tend to suppress the estrogen. All right. All right, so let's, we're going to cover the aspect of hypogonadism. So we'll cover 3 or 4 more slides, and then we're going to let you go for lunch. And at lunch, what we're going to have you do is look at those 3 to 4 videos, and we'll be finishing up on this probably after lunch, definitely after lunch, because we're going to talk, after lunch, we're going to talk about low T. And so what I want to do is talk about testosterone right here. So testosterone, obviously in the males, is going to be produced in the testes. In females, we do see, remember that the adrenal gland can produce sex hormones. So in the female, we see the adrenal gland as a site, and we also see the ovaries can produce testosterone. The testosterone, both in males and females, if in the blood, you can see it, as I mentioned a few moments ago, the testosterone is going to either be bound in sex hormone binding globulin, which is a protein, a carrier protein that will carry some of the testosterone around, or the testosterone can be free. And so when we talk about this in a little bit after lunch, you're going to see that sometimes what we really want to know is what the free form is. If there's something that happens with the steroid hormone binding globulin, that can increase the free amount, as I mentioned earlier today. We do see, especially in females, we do see that there can be some large and rapid fluctuations that can occur depending on different states that occur. Typically, we're going to want to draw testosterone for both males and females sometimes in the morning. Again, the morning labs usually pick that up without a problem. Now, in males, testosterone is a primary hormone. And one of the biggest concerns, probably the most common condition we have in males, is known as hypogonadism, which basically means underfunction or decreased function of the gonads. So, as I said earlier, the testosterone is produced primarily by the testes in the males. As I mentioned earlier, one of the concerns can be is that sometimes if we get an excess of androgens, what they can do is the androgens can actually be converted to an estrogen compound, particularly estrone and also estradiol. And this is getting back to what we mentioned. Somebody was asking earlier about how that increased testosterone or androgens may decrease sex drive and so forth. And the most people believe that when you get an excess of androgens, that you may get this conversion of estrogen or estradiol. That will then can stimulate breast growth. So that's the gynecomastia that we see. And we also see a reduction in libido. So we think the majority of this is probably due to the fact that in some individuals that this pathway may be more active. So how much it takes, we don't have really a threshold that would say in any one individual that there would be this, once you hit this level, you're likely to get estrogens or you're likely to get, like to develop gynecomastia. And as I said before, what we do see is the forms of estrogen we see is the sex hormone binding globulin. So the testosterone can bind to that. But we do see a small amount of testosterone bound to albumin. Okay, there's so much albumin compared to the other proteins, but the binding of the testosterone to the albumin is not as tight as what we see with the other. And then we have free testosterone. So there's really three different types of testosterone that are produced or that we see when we pull bloods, and we will, sometimes we can measure free testosterone or bound testosterone or total testosterone. And one of the things and this is why we're going to stop here, is because I want to sort of put you in the same situation, going back to the first slide we had. So if we call this primary hypogonadism, is if there is a problem with the testicles or the testes, okay? So either the testes are dysfunctional or the testes are absent, such as, for example, someone maybe has had the testes removed, maybe somebody had cryptorchidism, the testes didn't descend down into the scrotal area. So if the testicles or the testes are the problem, that's primary. If it is in the pituitary, that is considered secondary. What's happening there is pretty much luteinizing hormone is not being released, so it's not allowing the testes actually may function perfectly normal, and but the luteinizing hormone is not stimulating them to release the testes. And then the tertiary is basically the problem is really up in the hypothalamus. So the hypothalamus is not causing the release of luteinizing hormone, which is not causing the release of the testes. All three conditions we refer to as low T, okay? And so what I want you to do at lunch is I want you to look at these videos, and then what I want you to do is, so for each of these, so let me put it on the chat board here, or the chat thing here. So for primary, we know all of them are going to have low T, all right? So that's a common thing. So with primary, what I want you to tell me what you would have, and I've given you part of the answer, is what would happen with, let's say, LH, testosterone, and let's call it GnRH, okay? So we want to know what happens with primary. What would you see secondary? If you were reading the labs, what would you see with secondary with LH, T, LH, T, and GnRH? and then also with tertiary. HTGNRH. Okay. So that will be part of your thing. So if you were pulling labs, what would you expect to see with each of those? And since it's hypogonadism, I've already told you all of them will be low T. So you've got a one third of each of those answers. So look at that. And Aiden has already posted on the on Moodle the videos, and I just checked the links at lunch or at the last at our last break, and all the links were working. So and all the links were the particular ones. So there's like 4 videos, which there's one of the videos which is basically going to talk about the signs and symptoms of menopause, are being what's happening with menopause. They're all animations. So what's happening with menopause? What is happening with so one is for PCOS, which is the polycystic ovarian syndrome. One is a low T. One talks about amenorrhea. One is menopause, and one is the normal menstrual cycle. The normal menstrual cycle, I think, is the longest video, which is just an animation. And if you don't get to look at that one, you can look at it later, but look at the other 4 because those are things we've covered. Does anybody and then be prepared to answer these questions here when we get back. So we will start back at our normal time. As I understand it, Aiden, we will sign in just like we did, but with using the link. We'll have another link for this afternoon. And any other question? So if you guys also would be make sure that you click in there so that you can take roll. And Aiden, is there anything else any other announcement we need to make before I let them go for lunch?
No, nothing. Just that I usually take the attendance like 30 minutes into the class, but this time, because it's the first time with the Zoom, I let it to be toward the end. So then after lunch, I'm gonna run the poll once more, like 30 minutes into the class.
Okay. Just before I let you go, also, how is, other than me being a little spastic on this, is Zoom seeming to be a little bit better? I haven't seen a lot of people dropping in and off. So, okay, I'm glad to hear that. So if you guys give us feedback this afternoon too, because I mean, again, Dr. Steinem is really, we're sort of interested, and most people have said it's easier to log into. Aiden, I hope it's easier for you. So other than me getting sort of used to the to using these the things and occasionally bumping the slides, that's taken a little bit of things to do that. So I'm glad that this is working, and this may reduce some of the stress that you guys we've had to go through recently. So other than that, I will see you guys at 1 o'clock. So you guys have a great lunch, and we'll pick back up on these slides. And Aiden, we'll start right here with this particular slide. I'll pull the slides up, so it won't matter. So so I'm going to go ahead and log out, and I will see you guys after lunch. Y'all have a great lunch.
Awesome.
And Aiden, you've done a great job, by the way, today.
Of course. I'm gonna stop the recording for the morning, and there's gonna be another link for the evening class.
Sounds good. Thanks, Aiden.
Of course.